Right, I think I'm going to make a start then. Can I welcome everybody to the keynote session this morning? I'm Professor Alison Noble from the University of Oxford, and it's my pleasure to introduce the speaker today, and I'll also be responsible for managing all your questions. So can I remind you all to please post lots of interesting questions into the Q&A so that we can have a good discussion at the end. So as I said, it's a real pleasure for me to introduce Keynote this morning. This is Mihaela van der Schaar. She is the John Humphrey Plummer Professor of Machine Learning, Artificial Intelligence and Medicine at the University of Cambridge. She's also a Fellow of the Alan Turing Institute in London and a Chancellor Professor of UCLA. Career-wise, I did want to mention it because I know there will be quite a few earlier career researchers, and I also always get asked about my career trajectory. Mihaela has, people would call it non-conventional, but it isn't, as everyone's got their own trajectory. She started out at the Eindhoven University of Technology, where she did her bachelor's and master's degrees in electrical and computer engineering, and then she moved to Philips Research to start her independent research career, first based in the Netherlands, and then she went transatlantic across to the US, where she was senior research scientist, again for Philips Research. Having started a career for Philips, she then decided to become an academic and moved to UC Davis, initially assistant professor, and then subsequently was assistant professor at UCLA. At UCLA, she then went quickly up the ranks to associate professor, and then became the top type of professor, a Chancellor's professor in 2011. And that was in the Department of Electrical and Computer Engineering. Then it was a real delight to me when Mihaela was appointed the MAMMO professor in my own department, Department of Engineering Science at the University of Oxford, and that's where we got to know each other a little bit for a couple of years before she then went to Cambridge, where she's got her current position. And it's a very interesting position, and many of us work in different departments, but Mihaela is also going across different departments. Her positions associated with applied mathematics and theoretical physics, Department of Engineering, and the Department of Public Health. So a true interdisciplinary researcher. Mihaela's published widely, 250 journal articles, 275 conference papers as examples. She was elected an IEEE Fellow in 2009. And amongst the many awards and honours she's received in 2019, Mihaela was identified by the National Endowment for Science, Technology and Arts, that's called NESTA, as the most cited female AI researcher in the UK. So I'm really delighted that she accepted our invitation today. She's got a wide diverse of interests, and what she's going to be talking today, or the title of her talk, is the role of imaging in machine learning for healthcare. So thank you again very much, Mihaela, for joining us today.
Thank you very much, Alison, for the kind introduction and for inviting me. And maybe since you talked about the fact that I've had an unusual career, maybe I should just, since I saw at least one Romanian in the audience, I should say that I'm Romanian by birth. And actually, before moving to the Netherlands, I was a student for 2 years in Romania, in my own country, in computer science. So I encourage everyone to explore multiple careers and multiple countries. It enriches us all and gives us new points of view. So thank you very much, Alison and Mohammed, for inviting me to give a talk today. Let me just start by saying that while my PhD was on imaging many years back, better said on multimedia compression, processing and transmission, I've not worked much in this area for many years. However, I always feel that imaging plays a very, very important role, and this is definitely the case for healthcare. However, since I'm no longer working on imaging, what I plan to do today is to tell you about some of the challenges and opportunities that I see as a machine learner interested in healthcare, and where I feel that imaging can play a very important role when fused with other types of data, multimodal data besides imaging. So while I'm going to mainly talk about data that's not imaging, I'm going to use this particular icon every time I feel that machine learning can benefit from introducing imaging data and how I feel it can be especially used. And hopefully, since you all in the attendance are medical imaging researchers, hopefully you can discuss with me afterwards that you think that my thoughts about how imaging can be used are useful, or you think that I misunderstand. And I'd love to actually engage in this discussion with you and possibly establish collaborations if you are interested. So before I start everything, I'd like to thank my PhD students and postdocs, without which this research would simply not happen. And as you can see, they are very, very diverse from many countries and continents. I'd also like to start with a quote that motivates my own research. And this comes from Sir William Osler, the father of modern medicine. If it were not for the great variability between individuals, medicine might as well be a science, not an art. And it is indeed the vision of my lab to try to turn medicine from art to science by developing cutting-edge AI and ML technologies. One of the first things I'm going to talk about today is how I believe we can go beyond what people call nowadays precision medicine into bespoke medicine, and I'm going to define that. I'm also going to talk about how we can empower healthcare professionals of all sorts to better treat patients. I will not talk today, but an important part of the agenda, and I think one where imaging plays a very important role, is building healthcare system pathways and processes that are empowered using machine learning. And in the era of COVID, this is especially important. Also, while the focus of most of my talk will be on the individual and providing best support for treating and dealing with the patient at hand, of course, machine learning on a variety of data, inclusively imaging, will play an important role also for population health and public health policies. And I'm going to briefly talk about screening and when should, for instance, women be screened for breast cancer and potentially with what type of technologies. And this is part really not of precision medicine or bespoke medicine, but also a very important point for the public health research agenda, since there is no consensus as to when to screen and how to screen women that may be at risk. And last but not least, empowering researchers with new discoveries, both clinical and therapeutics using machine learning. So we know that patients are complex. They have different genetic background, environmental exposures, lifestyles, histories, and interventions. And this translates, of course, to different risks, inclusively different risks over time, but also variation in symptoms, health and disease trajectories that may evolve differently, and also responses to treatment. So while current view of personalized medicine or precision medicine often fits the patient to a pattern, and a lot of personalized medicine focuses on genomics, where, for instance, a patient with a particular set of genetic mutations may be fit to a particular pattern. In bespoke medicine, we try to often go beyond that and recognize and adapt changes in patterns as the patient is aging, may change their lifestyle, like changing countries, may have certain diseases that have started their onset, different morbidities and comorbidities that may impact others, or a patient may progress through a particular disease and may be treated in different ways, which may lead to different side effects. So all of that leads to really a need for a different view of machine learning, of medicine, using machine learning, where we can identify really these changes in patterns as the patient is progressing. And for that, of course, we would like to use a wealth of information, imaging, genetic information, as well as a variety of other information that's available in the healthcare records. My own research focuses quite a lot of electronic health records, but we do not look a lot at imaging. So I'm going to highlight the need for combining the type of research I do with imaging, but I'm not going to give too many concrete imaging examples. Also, I'm going to only briefly touch on genomics, but increasingly we are looking at genomics in combination with other healthcare data. And if we are able to do this well, then we should be able to provide actionable intelligence for clinicians and patients across the lifetime of an individual. And this could help us with an integrated view of prevention, screening, diagnosis, treatment, and monitoring at different locations, both at home as well as if the patient is admitted to a hospital, and enable the entire stakeholders to really use and have access to actionable intelligence. Again, I'm going to flag with this symbol every time I'm going to talk about imaging. I'm going to organize my talk in a set of challenges that I'm going to highlight, and then I'm going to tell you about some of our own research in addressing these challenges, but I think all the challenges I'm going to highlight deserve much more research. And I'm going to use most of the time, not always, but most of the time, cancer as an exemplary disease because it's complex. And I do believe that machine learning and AI can play a significant role there. At every stage of the cancer pathway, there are many decisions to be taken, and machine learning can play an important role. I'm not going to give a demonstration of what is possible, but together with the director of National Cancer Registries, I have given a Turing talk 2 years ago, where part of the discussion was not only the challenges we need to solve, but also we gave a demonstration of technology we have built on cancer for cancer support. And you can take a look at what's possible. I will not do that today. So let me start with the first challenge. As I mentioned, patients are complex and often may have different risks that may evolve and may change over a lifetime. And currently, often the risk of a patient is assessed one risk at a time rather than in combination. And usually only a small set of diseases, maybe specific cancers, more prevalent cancers, or cardiovascular disease may be assessed when somebody is visiting their general practitioner, their primary care clinician. But ideally, we would like to have at the push of a button the ability for a patient or a clinician to evaluate many scores. So we want to develop a holistic view of the patient health. So for that, we would like to be able to deal with risk prediction for many diseases, potentially considering different types of variables and different needs, and they may all change over time. And doing that using machine learning methods where we use one machine learning method that's trained again and again may be very difficult. And what we would like instead is to outsource not the clinicians, but rather to outsource ourselves. So we would like to use machine learning to do the crafting of machine learning scores. So we would like to use AutoML to empower clinicians and medical researchers to really build their own scores using AutoML. And AutoML can then select the machine learning model to use, which may be a linear model like a regression model, or may be a complex deep learning model, but also tune hyperparameters and potentially combine models. Of course, we will need to deal with missing data because missing data, inclusively data that's not missing at random, is important in such settings. And as a matter of fact, we do a lot of research on missing data imputation using ML. Value of information is important, and I'll go to talk a little bit about that later, because identifying what information should we use when issuing a prediction is important, because we can empower in this way clinicians to identify and measure the right information. Also, how to evaluate risk scores is important, and different metrics of performance may be needed, as well as uncertainty estimates, such that we know when to trust a machine learning model and when we should not. One tool that we have built a few years back is AutoPrognosis, which is an AutoML tool that is building pipelines formed on missing data imputation, feature processing, classification, and calibration. It selects models, but also combines them through an ensemble construction. It also issues explanations, and I'm going to talk more about that. and also is able to learn from meta-learning from other data sets. Is able to do this type of model selection and hyperparameter tuning through more sophisticated Bayesian optimization than the usual one used in AutoML. And the reason we need that is because we have entire pipelines. So the number of methods and parameters to choose at every stage is humongous. We have used this autoprognosis tool for a variety of diseases, from cardiovascular disease to cystic fibrosis to breast cancer to COVID-19. But what I'd like to show to, and you can use it yourself, the code is available. But what I'd like to highlight here is that you need to decide what data to put into a model. And part of this is trying to understand not only so you can use AutoML and autoprognosis to build risk scores for all these different diseases and many more. But an important point is what information should you feed in to this model? And what's the value, for instance, of a machine learning model as opposed to a regression model? Do we really need machine learning? So we have evaluated that a few years back, and we have looked at it in the context of cardiovascular disease. And we use the UK Biobank, which is a wonderful resource that has many types of variables. And we fed into it many different sources of information from UK Biobank, 470 something features. And we wanted to assess two things. One is what information is valuable, what is the value of information. And this is important for imaging because one may wonder, do I need a particular imaging test and for which subclass of patients? The second question we ask is, what's the value of modeling? Yes, I'm a machine learner, but I would like to know, does machine learning always add a value on top of regressions? Or are there settings where linear models are equally good? So an important point here will play also what type of imaging information we may want to add. And in our study, we were able to see, for instance, and assess the modeling gain. In other words, if we use all the variables, all the 470 something variables, what was the performance increase by using a complex AutoML model like autoprognosis as opposed to the Cox model? That's number one. Number two, we also were interested to understand what is the information gain. How much more are we going to gain by using all the sources of information for prognosis of cardiovascular disease, as opposed to the 7 risk factors which are usually used in the Framingham risk score, which is often used for cardiovascular disease? The reason I really like to bring this slide to your attention is machine learning work in medicine often forgets to assess these two sources. Often people choose a machine learning model, whatever they like, and they report these results. I like to encourage machine learning researchers, whether are in imaging or not, to often also report the modeling gain. How much better are they with respect to linear models? And number two, what would be the value of adding additional information? Because not always the more the better. Gathering this type of information in UK Biobank was very costly. And usually normal patients do not have 473 variables available for them. So you would like to understand what's the minimum amount of information to issue predictions that are valuable. So which variables to include and for which patients, and when is imaging useful in addition to something else? Because imaging may be at times more complex and more costly. To show our own results, the result was interesting because what you see is that for the overall population, the non-diabetic population, we have quite a lot of gain as opposed to a method such as a Framingham score, which uses linear models. However, for diabetic patients, which is a subset of the patient, the improvements were significant. And these improvements were both due to the modeling gain, but also due to additional variables, which were very important to include for diabetic patients. So an interesting investigation that I'd like to bring to your attention. Then often in machine learning, we stop after we make predictions, but we should not only do that. It's also interesting to look at time to event analysis, survival models, as well as deal with competing risks, because patients may have many risks that may play a role, especially as they age. Also, I'm going to briefly talk about causal models and temporal models later. So we have created over time AutoML tools not only for predictions, tools like autoprognosis, but also for all these other categories of models as well. And I'll talk about some of them a little bit later. But why I'm so keen about AutoML? Because we have a proliferation of methods in machine learning. The machine learning community is, of course, very creative. And we need to have ways to select models and decide which models are best for a particular data set and which models are most robust across a variety of data sets. So without AutoML, we will spend a lot of time just training and retraining models by hand, and that's not efficient or reproducible. So an important point I'd like to highlight here from an imaging point of view is that all these automated machine learning tools that we have built can use features from imaging, but are not using the raw features. It would be fantastic to extend many of these AutoML tools together with imaging experts like you to understand better the role imaging can play in addition to other features and at what stage of the disease of the patient. So integration of tabular data, inclusively longitudinal tabular data with imaging information is not often done, but I think would be tremendously useful. And one example where this would be extremely useful would be prostate cancer, where, and I'm highlighting here a recent study we have done with a collaborator in Cambridge, where we use information about MRI done on prostate cancer patients, but it's not the raw data like an expert like you would use, but rather just the report and features from the report. So I think more can be done. Now, analyzing competing risks. So often patients that are older may have multiple risks. I'm just showing here two: cardiovascular disease and breast cancer for an older patient. And we would like to know about these risks because often treating aggressively an older patient with breast cancer may lead to an increased risk on cardiovascular disease. So the patient may actually not die due to breast cancer, but may die due to treatments that maybe have been too aggressive for this patient, which also had cardiovascular disease. So looking at treatment as risks jointly as a competing risk problem is an important point, especially if you want to manage and prioritize preventive interventions. So machine learning methods for competing risks are needed to capitalize on complex data. And again, a lot of the work that we have done in this area beyond linear models. So currently, or up to recent times, often in epidemiology and biostatistics, people would just use cause-specific Cox models or the fine-grained models. And they are not very efficient because they cannot deal very well with complex information. So I'm going to show to you some ideas on how we dealt with this problem. But again, imaging information is not included, and I think it would be tremendously valuable to deal with competing risks. One way in which we have built these models for competing risks is through a very simple, well-known method in machine learning, multitasking. So we built deep multitasking learning models where we can build multi-layer representations of complex nonlinear interactions that cannot be captured by models such as Cox. And we have multitask learning for the different diseases and the different risks we want to represent. We did that in different ways. We did them with deep learning methods. We did them with multitask Gaussian processes, and we did them with multitask boosting methods. So different types of technologies with different types of learners, all of them capitalizing and innovating on the same idea that we need deep representations that are multitask. Let me now move to a second challenge, choosing the optimal diagnostic test for the individual patient. So often you may have fantastic methodology to do prediction, from instance, ultrasound. And of course, Alison is a world expert in that. And often as a patient, you would like to know what type of technology you should use to do a better diagnosis for a particular patient, but also for screening purposes, since some screening methodologies such as MRI may be more expensive. So an important part is what is the value of information, but this time what's the value of information over time and for an individual patient given their unique risk or genetic characteristic. So who to monitor, with what type of tests, when, and possibly in what sequence. Should I do first a mammogram? Should at the same time be done an ultrasound? Or should I do an ultrasound later only if I discover something? Should I do a more expensive MRI? When? And how often? So we have developed quite a lot of tools for personalized monitoring. Some of them involve imaging, but many of them do not. And even when we used imaging, we often used only the results of the imaging rather than the images themselves. So a suite of papers looking at personalized monitoring and value of information over time. And again, true access to imaging experts and imaging knowledge would be very valuable here. Let me show to you one example of what we have done. So quite a few years back, 5 years back, we built a system while I was still at UCLA that we call ConfidentCare. And that was a clinical decision support tool for personalized breast cancer screening. In the United States, often women at risk are screened with mammograms, ultrasounds, and MRI. And there was, at least at the time, and I still think is the case, no consensus as to when to use multiple imaging technologies. So we trained a support tool which was trained not on the real imaging data, but rather the reports as well as the outcomes to try to identify when additional imaging technology is needed. So this is one particular study we have done, and we show what classes of images would benefit from doing an ultrasound and an MRI, or only an MRI in addition to a mammogram, and when. In a more recent study, we have built together with my colleague Fiona Gilbert, who is a radiologist in Cambridge, MAMMO, which is a framework for human machine learning cooperation. So what's the idea here? Not replacing radiologists, but rather triaging the mammograms to decide when a radiologist should see the image or when a machine learning method based on, for instance, convolutional neural networks can be confident in classifying correctly this image for the particular patient at hand. This is important because in countries such as UK, often 2 radiologists are needing to seeing every image. That's not true in all the countries, but in countries like the UK, that's the case. And that may be very expensive because we don't have so many radiologists, and we better use the radiologists to look at the images that are indeed complicated. So we built a triage system that is able to triage these different images and decide when the system is confident and when it's not. And actually, this paper also appeared not only as a machine learning paper, but also as radiology paper. And actually, the radiology journal selected as a best paper of 2020. And again, what we have done on imaging, and this is one of the very few works we have done recently on imaging, is probably naive, and I would be very eager to hear what you think. What we have done is we trained actually a multitask CNN. And what's interesting is that we didn't only try to classify whether the woman has cancer or not. We also trained on a variety of other tasks. So we try to predict many, many different things related to microcalcification, speculated mass, conspicuity, and so on, as well as breast density as purely determined from the image to further improve these classifiers. What's interesting is to see that radiologists were wrong in some settings, classifiers were wrong in some other settings, and they not always intersected with each other. And also in some percentage of the cases, both the radiologist and the classifier were wrong. And these are images that we have evaluated this problem, which were more complex than usual because they were women at high risk. What's also interesting is that we build this ecosystem where we can now visualize when the radiologist is correct, the classification mechanism is correct, or when one is wrong and the other is not, such that they can discuss with each other if they don't agree and come up with a consensus. So building such tools, I think it's important, such that clinicians and radiologists can have dialogues with the machines and understand and come up with consensus and understand when they may be wrong and they may need support, and conversely identify when the classifiers are wrong and interject. So we also evaluated this in settings where we have only the classifiers making decisions, only the radiologist making decisions, or combinations of them. And what's interesting to see is actually that, of course, a hybrid model is probably the most useful. So not having them as double readers, that seemed overkill. Most of the time, the sweet point was achieved in a setting where the machine learning itself knew when it's confident and issued confident and correct predictions, and when it was not, and the image was sent to the radiologist. So this hybrid model seemed to be the most effective and cost-effective. And you will see that in this case, around roughly half of the images were sent to the radiologist and half the classifier correctly and confidently classified. Now, let me move to another scenario, making predictions over time on the basis of longitudinal data. So we know that often patients may evolve over time differently. This is the reason I advocated this paradigm shift from personalized medicine to bespoke medicine, because patients may move across phenotypes in different ways as they are treated differently, but also depending on a variety of factors, inclusively maybe different types of morbidities. And learning from longitudinal data is complex because we have irregularly and informatively sampled data. We may have only limited supervision, and by limited supervision, I mean both clinical annotation, codes, etc. But even images, you can almost think imaging information provides a very powerful tool for assessing the trajectory of the patient, whether the patient indeed is going to do better or have recurrence, for instance, in the case of cancer. And imaging is not always available. It's available only at some moments in time. How to integrate this information over time and history, how much history matters, is important, and it's especially important in we have multiple morbidities. And when building such models, we want to make sure that we do personalization rather than one-size-fits-all models, as well as interpretable models. And if you want to read more about our own work in this area, you can see at our website papers selected on the time series agenda. I'm going to just highlight a few and discuss the role of imaging. So one of the important things in using time series data is for early diagnosis of cancer. The reality is that if you catch cancer late, very little can be done, or much less can be done. So you'd like to identify cancers early. And for that, longitudinal models of disease progressions are important. So we want to use a variety of input data, inclusively imaging. We often have not used imaging, but imaging is very important, of course. And use a variety of symptoms, vital signs, and other types of information, and learn trajectories of disease that can enable us to talk about disease progression, start of disease, as well as severity of disease. So what we would like is to have models that are data-driven, accurate, and interpretable to issue such dynamic forecasts as data is progressing and more data is acquired, that are personalized to the individual and can do risk progression, risk prediction, but also can determine likely diagnosis early. Again, what's the value of imaging and when should imaging be added as an important tool to improve diagnosis or prognosis is something that will be interesting to understand. So usually we would like to build models that are learning from a variety of electronic health records data, and then train these models from the data we have, and at runtime issue forecasts for the patient at hand. And on the basis of this also maybe unravel new understanding of how disease progresses, subgroups of patients that may behave differently, as well as enable personalization. When we started this research agenda almost 8 years ago, we looked a lot at Markov models, and indeed Markov models are still a workhorse in many settings. But a disadvantage of Markov models is that they are only focusing on the current state of the patient. So models, for instance, for prostate cancer that are often in use as state-of-the-art are using this type of Markov models. We clearly would like to move beyond Markov models, and again, early on, we started to look at hidden Markov models because they will enable us to encapsulate in latent hidden states a variety of information that's associated with the current observations. But early on, we discovered that just Markov models are not going to be enough. We started to look at hidden semi-Markov models because the duration in the patient is in a particular state matters. So it is not only the current state, but also the duration in a state that matters. Also, the patients may be absorbed in different states. These states may be states in which a diagnosis, potentially through the use of imaging, has been made. And it enables us to learn more effective trajectories. So the move from Markov to hidden semi-Markov to hidden absorbing semi-Markov has led to significant improvements. More recently, we started to look at deep learning methods because semi-Markovianity, while useful, is still at times not enough because the entire trajectory of the disease, non-stationary trajectory of disease, often matters. So just semi-Markovianity is not enough. The entire trajectory may matter. And for that, we are going to use actually past states as being informative as well. And the weights that we allocate to the past states' importance when making predictions for the patient at hand are important as well. So I'm not going to go too much into this. I'm just going to say that this uses a new attention mechanism. Most of you who are familiar with machine learning may use already attention mechanisms, but here was a new method of attention because we put attention not on the feature space directly, but rather on the state space, the latent state space. And in this way, we have much more powerful and robust longitudinal models than if we would put attention at the feature space, which will be less robust. Then, if we are able to have such models, we can start to do early diagnosis. How? For instance, in the training data, we may have a patient like this one, which was diagnosed, for instance, through imaging in stage 3 of cancer, and maybe bowel cancer. And what we could do then, we could go back and see that actually a variety of symptoms and comorbidities have been diagnosed earlier. So we can then use this type of information to learn the value of different symptoms and different comorbidities being diagnosed at different moments in time. Then at training time, we learn this type of trajectories and the probabilities of diagnosing and measuring different types of diseases or symptoms. And then at test time, as a patient is exhibiting, for instance, a symptom, we know that the probability maybe of having a different morbidity at a later time or cancer at a later time is increased. And we can issue this type of probabilities for the patient at hand. And again, what is the role of imaging and early imaging, and at what moment in time in identifying this type of trajectories, and what will be the value of discriminative value of imaging plays an important role when integrating with other information. So integrating imaging in this type of, for instance, attentive state space models will be a very interesting component. Now, in some other work, we looked at when should we acquire information. So in models like this one, the information is there, and we assume that the information is available. And if the information is not available at some moment in time, we would, for instance, deal with missing data either through imputation or not through imputation by using, for instance, the timing of the observations as being informative. Another way to go about this would be to say, let us acquire information actively through an active sensing process, which would allow us to have a dynamic personalized screening. So whenever we are uncertain about the evolution of a patient in the future, we can decide to screen, for instance, through imaging or through other modes of screening. So, and determining what's the best time for a patient to be screened and potentially with what technology over time is what was the focus of this NeoRIPS paper. And what we show here is the importance of the timing of screening. And we believe this is important because currently patients that may be diagnosed with a particular cancer are often screened in a one-size-fits-all. And it is clear a waste of resources. And at the same time, patients that may be benefiting from more frequent screening or earlier screening are not screened as efficiently because they are screened at the population level and may be too late due to the overall cost for the average population. So again, I feel that this is a very begin in the agenda, an important agenda of determining how to screen, when to screen, and with what technology to screen patients given entire histories. And again, important role for imaging here. Another interesting aspect is dealing with morbidities and comorbidities. We all know that different diseases may influence the onset of other diseases or the progression of other diseases. Yet technologies in this area of comorbidities are quite primitive. Often they are one size fits all, and people build networks of diseases in a static way. So the two advances that we have recently made was, number one, to come up with personalization, where, for instance, based on genetic information and other information of a patient, we come up with a personalized morbidity network. And secondly, we do that into a dynamic way rather than a static way. So rather than coming up with a network and that's fixed, depending on the timing and intensity of a particular disease that remains untreated, the impact on subsequent diseases will change. So the dynamic aspect. So in a paper last year, we started to look at learning dynamic and personalized comorbidity networks. And we did that using a deep diffusion process, where we are showing actually that you would like to look at the order, onset, and timing of morbidity, and how long this morbidity was untreated, and its intensity as an important information in impacting other diseases and their evolution over time. So building this multidimensional point process through this deep diffusion process enabled us to do a much better set of predictions over time of the evolution of other diseases. This was done for bowel cancer, especially based on the UK data set on cancer. And again, we used only the ICD-10 codes and some other very rudimentary information. But if we would have used imaging information, my guess is a lot more interesting and better results would have come up. Again, let me go back to say that all of this can be put into a framework of automated ML, where this type of methodologies can be used for different diseases simultaneously. And before finishing this talk, I want to just very briefly talk about treatments, because often we don't want only to make predictions, we also want to treat patients. And we need to identify what treatments are best for a patient. And we know that these treatments are often heterogeneous. So we would like, on the basis of electronic health record data, which should include imaging information, to determine how to treat a patient. Shall we do chemotherapy? Shall we do radiotherapy following a surgery? If we do chemotherapy, what type of dosage we should be using? And potentially, how shall we change decisions over time as to what treatment to give? All of that follow under the agenda of personalized therapeutics, where we are trying to learn individualized treatment effects from observational data. Currently, when doctors make decisions about patients, are often using information from randomized controlled trials. But unfortunately, it is well known that these randomized controlled trials are focusing on the average patient rather than personalized to specific class of patients. Yet treatment effects are known to be heterogeneous. So there are many limitations by using just randomized controlled trial for estimating what treatment should be given to a patient, because such RCTs are often including non-representative patients, patients that may be not all, maybe only younger patients rather than elderly patients that may have comorbidities, which are the representative patients that usually will get the medication. They are focused on very specific questions, usually are trying to identify whether a treatment works or not, rather than taking the entire complexity of healthcare, inclusively competing risks from giving the medication. They are small sample sizes, time-consuming, and often certain types of trials cannot even be conducted because it would be unethical. So what we advocate is as a supplement, not as a substitute, to use individualized treatment effects from observational data to complement RCT trials, where we learn from observational data that really captures the complexity of healthcare, where representative patients are treated. And if we can do that well, it enables us to have scalable and adaptive implementations that are fast in deployment using machine learning. So how can we do that? We can do that using causal inference models. And we can include a variety of patient features, inclusively imaging. Not often, so the causal inference agenda for treatment effects is very vibrant. But unfortunately, I see very little use of imaging. And this is, I think, a missed opportunity, because imaging could be very powerful, both as a variable that can be included for the patient, as well as a variable that can be used for the outcome, because often how effective a treatment has been for a patient is evaluated on the basis of an imaging information. So for instance, histopathology as an input for imaging for the patient features, and then outcome potentially an MRI or an ultrasound for the patient. Usually what we want to answer here is causal inference problems and answer counterfactual questions. What would have happened to this patient if we would have treated them differently? Or if we do that for prospective data, what are the different options for treating this patient given their unique characteristics and features X? Should we treat or shouldn't we treat? And usually we learn that from observational data sets that only contain, of course, the factual. We don't know what would have happened otherwise. So this is a complicated machine learning problem that's different from a simple supervised learning problem, because we do not have labels. We just know the factual outcome rather than the counterfactual outcome. We also need to deal with other challenges. We need to learn to model interventions. Shall we model this as features, or shall we model this differently? And also deal with selection bias, because doctors do not close their eyes and decide whether to treat or not. They have their own biases and they are present in the data, and we need to deal with these biases. So this represents a very important problem. There are many seminal works about this topic in statistics and econometrics. And one of my personal favorite books, if you want to read a background book on this topic, is the book of Hernan and Robbins. So what machine learning can add to this agenda? It is the flexibility of the models we can build using machine learning. We can model treatment assignment variables in different ways, in different types of architectures. We can deal with selection bias in very effective and innovative way by training different types of architectures. So machine learning can really add a lot on top of statistics and epidemiology to the causal inference agenda. And indeed, in the last 5 years, there has been a lot of work in this area. Early work at MIT started this agenda in machine learning for binary treatments. And since then, a lot of researchers have contributed to it. And our own lab does a lot of work in this area, looking at multiple treatments, continuous treatments, treatments over time, combination of pharmacological model with machine learning, data-driven solutions, etc. So again, a very vibrant area of research. I'm not going to talk a lot about it, but I'm just trying to say that imaging information will be very valuable, and I not often see that being included. Especially when talking about treatments over time, because in these settings, we want to know when to treat and how often to treat and when to stop. And the role of imaging in this progression would be very, very important. So right now we are using static information about the patient as well as longitudinal information and different timing of treatments. And imaging would play a very important role, and the time at which the imaging was made in determining whether indeed certain alternative treatments would have been better, such that we learn on behalf of subsequent patients. I will not, in view of time, go too much on this because I think my time is almost up. I'm just going to say that where machine learning has helped a lot in this agenda was to deal with bias from time-dependent confounders. And what are time-dependent confounders in these longitudinal settings are variables that are affected by past treatments, which then influence future treatments and outcomes. The conventional way to deal with that has been to do inverse probability of treatment weighting, which is what the initial seminal work on marginal structural models tried to do, which we try to enhance using recurrent marginal structural models. But this was not very effective because such methods are usually very numerically unstable and lead to high variance. So these methods that are based on inverse probability of treatment weighting are not very robust. So instead, what we have come up with is a method using representation learning, where we build counterfactual recurrent neural networks to balance these different representations and deal with time-dependent confounding bias, where we use sequence-to-sequence architectures to learn what would be the effect of intervening at a particular moment in time. The reason I wanted to show to you this architecture is because here is where imaging can be easily added as a variable and would allow us to determine through this sequence-to-sequence counterfactual neural networks, estimate what would be the value of having additional information and would that change potentially the treatment. So combination of this methodology that I'm highlighting here with imaging, I think would be natural and very, very interesting. At this stage, I'd like to kind of move and just finalize the slide, the set of slides and presentation by saying that we need really to build a different way in which humans, clinicians, and patients are interacting with machine learning. We do not believe that machine learning is going to replace clinicians. Quite the opposite. We believe that it will empower them. And for that, to build this new partnership between man and machine, we built a new field. We are starting to build a new field that we call quantitative epistemology. And this is a multidisciplinary research field that will involve machine learning, but also cognitive science, behavioral sciences, and many others, to try to understand how can we empower rather than replace humans. If you are interested to hear more about quantitative epistemology, and I think I wanted to highlight that again because I think imaging researchers can play an important role here, we have had a session yesterday actually dedicated to this topic. So we started due to the pandemic and because my own students cannot go to conferences and interact with others, other researchers, we have started in September 2020 a set of engagement sessions that we call Inspiration Exchange that's dedicated to everyone that's interested in machine learning for healthcare. If you are interested to join us and discuss with us, please go to my website and subscribe and join us in discussions about what type of tools we should build together and how can we break across disciplines to build more powerful tools for machine learning in medicine. This will enable us to really catalyze a revolution in healthcare, both by introducing bespoke medicine that's truly personalized to the patient at hand, empowering healthcare professionals, doing better population health and public health policies, as well as build better healthcare systems. And finally, cross-disciplinary is key, and this is what we have tried to do and started to do in our Cambridge Center for AI in Medicine, where we are collaborating across disciplines between machine learning, genomics, as well as medicine, as well as with a variety of companies, inclusively pharmaceutical companies. However, the center does not have imaging expertise. Instead, it tries to collaborate with other centers and other researchers who are experts in imaging. So if you are interested in collaborating with us, please reach out. Thank you very much.